end of the session. Now join me to welcome our Dr. Qusay today, and a very warm welcome, Dr. Qusay. The floor is yours.
Thank you so much. Thank you so much. So let's kick start. You all know what's MSRA, but let's start with the basics. So in this presentation, you are expecting to know about the scoring system and the recent cut-off scores in round 2. We are talking about GP, psychiatry, anesthesia. That's important to be up to date about the last score required to get into these training programs. We will be talking about the GMC new requirement for the application and the strategies for the MSRA and real examples for the SJT. First of all, the MSRA is a computerized exam of 2 parts: clinical reasoning and professional judgment. Clinical reasoning is the clinical exam. It's very classical. You have been through doing that through your medical school and afterwards. The professional judgment is it's so-called the ethical exam. It's not an ethical. We are exploring that in a minute, but it's the professional judgment. And you will be needing this exam as part of your application. As part of your application, if you are applying for radiology, nuclear medicine, ophthalmology, anesthesia, whatever, so many specialties in the UK. So part of your application is to sit for this exam, to pass it, not just to pass, to score the cut-off score. And again, the cut-off is subject to the competition and the specialty itself. So, for example, the cut-off score to be shortlisted in radiology, for example, is not the same for GP, is not the same for psychiatry, and so on. So, what is the format of the exam? Again, it's two paper. It's of two paper, 2 parts. The SJT, the professional dilemma, it's 50 questions, as you can see. 8 of them are pilots questions. Pilots means they are not counting toward your final score. However, you wouldn't know which is which, so you got to do all of them. You need to finish that in 95 minutes. So you have 1 minute and 55 seconds almost for one question, which is very less time, to be honest. In the clinical part, so you will be doing the SJT, then you'll have 5 minutes break, then the clinical part. So the clinical part is 97 questions, 11 of them are pilots. You got to do them in 75 minutes. So there is a time pressure. So the MSRA scoring is not scored on percentage. It's not about how much do you score correctly. It's not like that. It is ranking you against your peer, against the cohort, against your colleagues. So they use the bell curve. So what does that mean? So let's take an example. We have, as we mentioned, the clinical and the SJT. The clinical is the easiest to explain because it's a binary scoring. What does that mean? They will ask you MCQ question. Either you got it right or wrong. So it's binary, 0 or 1, correct or incorrect. In the SJT, because you have 2 type of question, ranking and 3 best of 8. So in ranking, you might not score 100% correct, but you might get partially correct answer. So the ranking questions is out of 20 marks, so you might score 18, 16 according to how approximate your answer from the ideal answer. If you want to explain how do they score us, let's take the clinical part because it's easier to explain, and you can apply that to SJT. So the first step, they will take your raw score. What does that mean? So as we mentioned, we have 97 questions. 11 of them, they are not counting. They are pilot questions. So we have 86 questions. 86. So let's say you scored 64 questions correctly from 86. So you got 64 out of 86. Okay? This is the first step. Then the second step, they will use a computer to calculate the cohort statistics. What does that mean? Step 2, now your raw score was 64. Keep that aside. Now they are collecting the scores of everyone, and they are just taking the middle 68%. So the cohort, you will have some outlier. They're scoring very, very high. For example, 86 out of 86. They don't count these people. And some people, they are scoring very low. They don't count these people. They take the 68% in the middle. The 2/3 that they are in the middle, they're scoring close to each other. So they take these people. From that 68% from that cohort, they will calculate the average and the standard deviation. So let's say the average was 59 out of 86. Let's say the average was the average of the two-thirds of the 68%, the people in the middle. So the average of them was 59 and the standard deviation was 15. So standard deviation means how the scores are spreading. So let's say now your score was 64, the average was 59, and the standard deviation of the average of the two-thirds of the people were 15. Then, and this is the bell curve. So look at the middle. If you can see my cursor here, from 70% of the people to 30%. Let's look at this here. This is the people in the middle from 15.9 to 84.1. These people in the middle, if you calculate them, they are 68. So these 68, they will decide the average of the cohort altogether. They don't count the outlier here or this outlier here. So then the step number 3, they will take your score, which was 64, okay, against the average of the cohort. The average was 59, okay, and they calculate your Z score. What is the Z score? Your raw score, which is 64, it was 64, and minus the average was 59. So you are above the average by 5 points. They divide that by the standard deviation. Why? So they want to know how many standard deviation you are away from the average. The average was 59. How many standard deviation you are away from the average? And actually, you are 5 points away more than the average, which is 1/3 standard deviation, because the standard deviation is 15. You are 5 marks above that. So you are just 1/3 standard deviation. So your Z score would be 0.333 here. So you are 1/3 above the average. You are 1/3 standard deviation above the average, which is 0.333. So your Z score is 0.333. Then, if you calculate here, if your Z score was 0, that means your raw score is exactly on the average. You are just on the average. So your Z score is going nowhere from the average. If your Z score was 1, you are complete standard deviation above the average, which is very, very high. You are 1 standard deviation above the average. If your score is minus 0.5, that means you are half a standard deviation below the average. So it works this way. So Z score is very important. Again, step 4, they will mirror that image. They will create an imaginary marks. They want the actual mark to be, the average is 250. So they are presetting the average 250. So if you are scoring the exact average, which was 59, your actual score would be 250. So always the average is 250. Whenever you are scoring 250, that means you are just scoring the average. And they are creating an imaginary standard deviation, which is 40. Okay, so let's apply this. So your final score would be your Z score, which was 0.333 here, 1/3, times the new standard deviation they created, which is 40. So you are 1/3 of this 40 plus the average, which is 250. I know that's complicated. Let's repeat that again. Now, my Z score was 1/3. I'm just 1/3 above, 1/3 standard deviation above the average. Okay, so that 1/3, that will multiply that by 40, which is the new standard deviation. So you are 1/3 of the 40 above the standard deviation, above the average, which is 250. So from the 250, you are 1/3 above. So 1/3 times 40 plus the 250. So your actual score would be 263. So your score now, 263. What does that mean? That means I'm 1/3 standard deviation above the average. And they will apply that to the SJT as well, and they will combine both. So if you are scoring 170 in one of the exams, either the SJT or the clinical, that means you are 2 standard deviation below the average. You are 2. That's very low. If you are scoring 210, that means you are 1 standard deviation below the average. If you are scoring 250, that means you are exactly on the average. If you are scoring 290, you are complete standard deviation above the average, which is very high. If you are scoring 330, that means you are 2 standard deviation above the average. Again, let's say you had a very difficult exam, clinical exam, and the average row was not 59, was 53. Most of the people that are scoring just 53. And your score was 64 as it is. Now you are 0.9 standard deviation. You are scoring the same mark, which is 64, but the average is low because the exam was difficult. So that means you are automatically now not just 1/3 standard deviation, you are 0.9, you are almost 1 standard deviation above the average. So your final score will be 286. You are scoring the same score, but the average was low. The exam was difficult. So that means it is not your raw mark, it is the average. How far you are from the average. If you are very far from the average, you are scoring high. If you are very low from the average, you're scoring low. So you are scoring the same exact mark, but because the average was less, now you are scoring, instead of 260, now you are scoring 286, which is very high. So that's important to understand. And this is very important statistics from the round one in 2025, last year, this year actually. So they are publishing the bands of the two papers. So in the clinical part, you can tell here, you can tell, for example, 19% they are scoring from 230 to 250, the average 19%. It is the same here because, as we agreed, the average would be the same in SJT. But look at this here. The people that are scoring above the average, just above the average, they are 23% in clinical part, but they are just 16% in the SJT. That means the SJT is more is difficult for the people. 20% they are scoring between 270 and 290, 20%. But in SJT is just 11%. 9% in clinical part they are scoring above 290, which is very high, but just 4% they are doing that in the SJT. However, people that are scoring more than 310, they are just 1% in both, because this is very high score. So 1% here and 1% here. So I'm trying to say in SJT it's harder and people are scoring less. You can tell here 5% scoring less than 170, 5% scoring between 170 and 180. It is just 3% here. So it is more difficult. So why it is fair they are using this? Because the scaled score is standardized performance across the year and across the cohort. If the exam was very difficult, one of the modules, for example, you would be fairly treated against your colleagues. So that's why. Just to let you know, the actual exam comprises nine, 6 to 9 modules. So at the day of the exam, there will be 9 modules circulating all the time for the 2 weeks, because the exam window is 13, 14 days, something like that. So every day you will have the same 9 modules. So let's talk about the SJT now. They are examining you or the themes of the questions in the real exam of 3 topics: either professional integrity, or coping with pressure, or empathy and sensitivity. One of these 3 topics. We have done some poll and voting and like questionnaire after the exam in September to know what was difficult and did they change anything. And the answer was yes, they changed a lot. However, as you can see here, 56% of your colleagues saying they found the SKT section is more difficult than expected. And 44, I think, they said it was as difficult as expected. And 0%, they're saying it was easier. None of them, they said it was easier. So more than half of the cohort, they're saying it was more difficult. We knew it's difficult, but it came more difficult than we expected. Then we've asked, what was the difficult bit? Is it the time management? Is it the options? And we had a thorough questionnaire. So 54%, they are saying the tricky point was the options. They've changed the style of the option, and we are discussing that in a minute. Usually, classically, let's say, the time management was the major issue, but it is not anymore. So 30%, 31%, they are saying, okay, the time was the major difficulty, but 54%, they are saying, no, it is the options. We could not figure out the options. They were very short and very tricky. So now I think they've listened to us because we were complaining about the time management. The time is not enough for 50 questions in SJT. So they made the options very short. They used to be very lengthy. So they made them very short, concise, but very tricky. So people are complaining about the trick options more than the time management now. You have to know that. So what is the new style they've adopted in September exam? They brought more scenarios on how to deal with your three topics mainly. One of them, how to deal with the feedback. It wasn't the case. Usually, they are asking about gift from patients, autonomy, confidentiality, breaching confidentiality. But now they are changing the main topics. Most of the questions were about the feedback. How would you deal with the feedback? If someone giving you bad feedback, what would you do? If your supervisor is telling you this. So you have to really master the feedback topic. Again, they're asking so many questions about the academic activities like audits, presentations, researches. They have been asking about this in the past, but not as heavy as now. And and they are asking about inter-colleague relationship. You have a conflict with your colleague. How would you deal with that? You are a third party watching two colleagues. They are arguing against each other. So many questions about that. However, they are bringing less frequent questions about receiving gift from patients, relative asking about updates. These classical topics, they are less frequent now. So again, you might have one module, the whole 50 questions just talking about these three topics. If you are not mastering this, you are losing your exam. And I find that, to be honest, a little bit unfair because it meant to be like well distributed. So if you are missing one topic, you are compensating the other, but it's not the case, to be honest. They are asking about two, three topics, and that's it. From other angle, you might say, okay, they are looking for a potential ST1 or CT1. He's a junior registrar or house officer. So they need someone who is very good to deal with the colleagues, how he's handling feedbacks. It makes sense, but it's really difficult. If you are missing these three topics, you are missing the real exam. So again, they are giving very brief ranking options. This is something brand new. And in one of the modules, they brought very lengthy options regarding the three best of eight, because as we mentioned, we have two types of question, ranking and three best of eight MCQs. So in one module, one specific module, the options of the MCQ question was lengthy, so you need to focus on that. And they again, the GMC Good Medical Practice, which is the main source, has been updated in January 2025, this year, at the start of this year. So you need to keep yourself updated and read the new updates because they use that in the new exam. So let's have real example here. I would love it if someone could volunteer to do this question. There is no judgment. It's not an exam. We are just doing this presentation to help each other. So any volunteer to do this question? Anyone want to volunteer? Come
If
on, we are.
anyone, if anyone want to volunteer, just feel free to unmute yourself. If not, I'm happy to volunteer.
Oh, we have 50 participants here. Someone should be brave enough to volunteer. Just to read the question. You're not doing so much.
I can volunteer.
Yeah, please go ahead.
Okay. SJT example. You are conducting a ward round with your FY2 colleague, Dr. Lee. While reviewing one of your patients, Patricia, you see that her chart indicates that she has refused medication for the past week. It is not critical for her short-term health. However, her symptoms are unlikely to improve if she does not take her medication. Dr. Lee says, "You don't seem to care about getting better. You may as well go home," and leaves the room. Patricia looks upset by Dr. Lee's comment.
So what? Yes. Before you are going to the options, what was your impression about the question? What do you think the examiner is asking you about? The topic or the concept? Or what do you think?
About teamwork and the dynamics
Yes.
in teamwork.
Very good. Very good. So my relationship with Dr. Lee, how would I support him? That's very good. Is there any other topic in this term?
Interaction with the patient or how to speak to a patient who seems aggrieved.
Very good, very good. And patient care as well. We need to take care about this patient to take our medication to feel better, isn't it?
Yes.
Very good. So can you read the options if you don't mind?
Okay. A, report Dr. Lee to the consultant. B, reassure Patricia that Dr. Lee didn't mean it, but he's just having a stressful day. C, do nothing in the moment, but make a note to discuss later. D, overtly disagree with Dr. Lee, to show her you are on her side.
Do you have any provisional answer for that? What's your
Uh,
ranking? Because
my-
in the real exam, they are bringing pretty much similar options. Very short
Mhm.
and 4. They are not even 5. They've changed that. I think because of the feedback of the time and things like that. So you will have a stem, I would say moderately lengthy stem and very short options, and they are for not even 5. So do you have any provisional answer?
I think the first one I would say is C,
Okay.
B, A, and then D.
C, B, A, and then D. So may I ask why would you do nothing while the patient is upset and someone is being rude to the patient?
Oh, I'm sorry. I would say B, C.
Actually, C is the right answer.
Oh, okay.
Yeah.
I just don't think because of my relationship with Dr. Lee, I wouldn't want to confront him in front of a patient.
Okay.
But I
That's
want
very
to
good.
discuss it with him in private.
Very good.
Okay.
So C, B, A, and D.
Yeah.
Okay. So when you have some question like that, first of all, is there anyone want to try, or should we go ahead? If no one is trying, I can just continue. Okay. So when you read a question like that, you have to start very carefully, because every single line will carry some hints and tips for you. This is the only way you could sort out the SJT. So let's start from the beginning. You are conducting word round. That's very important hint. Word round. Don't know how can I just give me a minute, sorry. What was that? Oh, what happened? Okay, so this is the first hint. It's a word round. What does word round mean? That means now currently we are taking care of the patient.
Yes.
That means I'm in the middle of the ward round. So anything that will interfere with the ward round and taking care of the patient, I will just discard that because I'm in the middle of the ward round. That's very important. That's number one. And they are emphasizing that by saying while reviewing. So you are actually in the ward round. So the patient refused. That's fine. And it is not critical. That's fact. So there's no like immediate patient safety. That's fine. But it's for the quality of life and symptoms management. Dr. Lee apparently became very rude. He has no right to say if you are not taking the medication, leave the hospital. He has no right to say that. So he is mistreating the patient, which is not acceptable. And the patient is upset. That's a hint for you. So let's challenge every single answer. Report Dr. Lee to the consultant. Is that something you could do? I would say to report someone initially, that's unacceptable. Is there any case where I'm safe to report? The answer is yes. We have to know that. When could I report someone? If I've approached him previously, number one, and he's not responding. This is one criteria or one term. The other one is if he's really understanding what he's doing is wrong and he is insisting to do that. So if I fulfill that two terms, then I can immediately report. Is it the case here? No. I haven't approached him before, and I cannot assume he's understanding what he's doing is wrong because no one explained that to him. So A is somehow premature and exaggerated response. So it's not a favorable one. Keep it down. B, reassure Patricia, reassurance for someone who is upset. That's very good. Start. So reassure the patient that my colleague did not mean it. Okay, is that fact or I'm assuming? Sometimes I'm safe to assume that my colleague is nice and he didn't mean it. It is good practice to do it sometimes. Is it the case here? The answer is definitely no. Why? Because I have a fact. They mentioned some story for a reason. He has been very rude. He has no right to say, if you are not taking the medication, you go home. No one should treat the patient this way. This is very humiliating. So I'm pretty sure he was rude. So I cannot reassure her he didn't mean it. That's lying. That's I'm taking the side of my colleague, especially when the patient is upset. I cannot go for someone who's upset, telling her he didn't mean it while he meant it. Not just like that, look at this, but he is just having stressful day. Like I'm telling the patient, you are upset. I understand that. But from now on, you have to expect us mistreating you, being rude. If we had a stressful day, you have to accept it. And that is very humiliating. This is against the GMC. GMC is saying you have to treat patient with dignity and respect and something like that. It's not a justification to have a stressful day so you can be rude to the patient. So B is totally dismissing the doctor-patient relationship, the patient dignity, which is very catastrophic here. A, I'm not doing favor to my colleague because one of the objectives in the question is inter-colleague relationship. The other one is to take care of the patient and patient dignity and doctor-patient relationship. So A, maybe preserving doctor-patient relationship, but is harming my relationship with my colleague. That's not nice. B is going the other way. I'm standing blindly with my colleague and I'm dismissing the patient concern. I'm telling the patient, you have to expect us to treat you badly if you have a stressful day. That's very bad. So C, do nothing at the moment. That's carrying some delay. Why would I delay treating this situation? The answer is because we are in a ward round. That's very important trick. Again, if you are in a ward round, that means you are actively taking care of the patient. This is clinical care. This should supersede any non-clinical business. So if you are comparing carrying on the ward round, taking care of the patient, that is your primary job, or prioritizing like non-clinical business by saying sorry and addressing someone who's upset, you have to prioritize the clinical job. Does that mean if they change the setting, they say, for example, you are during the ward round and you are seeing the last patient, no patient after that, would that change anything? Yes, because the only reason for me to delay treating this situation is I'm actively taking care of patient. Now there is nothing like that, so I need to stop and address the issue immediately without delay. But now I'm in the middle of the ward round, so doing nothing now is good because I'm prioritizing clinical needs, but make note to discuss it later. That's very good. So, is there any other situation where C would be incorrect, especially, or let's say, even though we are in the middle of the word round? The answer is yes. Anyone could tell me when would C be a wrong option, even if we are in the middle of the word round? What could they change? Because they are playing around these tricks. What could they change in the stem to make C a wrong option?
I think if it's critical medication for her short-term health, like if the medication she's refusing to take is urgent.
That's very good, but again, none of the options is talking about. By the way, I made up these options. So none of these options is talking about the clinical care. All of them they are talking about just the dignity, respect, and upsetness. That's very good, but if they kept one of the options talking about medication, things like that, you should prioritize patient care. I agree 100%. But I'm keeping the same options, the 4 options. None of them is talking about medication or anything. But what could they change? If they change,
Poss-
yeah,
yeah, possibly if the habit of Dr. Lee has been on talking down to patient has been recurrent.
okay. So if this is not the first time, you mean?
Yes.
If this is not the first time, I will report him. Yes, but still, C is not a bad option. Yes, Dr. Mohammed Hussein.
If the colleague passes any racist or abusive comments,
Like what?
like just like insulting.
Okay, very good. Oh, very good. So we had 2 nice options, nice answers here. If the comments was racist, derogatory comments, I cannot stand this. But again, I will correct this a little bit. It's not blindly, it's not 100% correct. And someone else say if that's a pattern. So the answer that I'm looking for, yes, Dennis, yeah. Yes, Dennis.
What I think is if maybe in a situation where it said that the patient wasn't upset, the patient
Oh,
didn't look upset.
if the patient is not upset, you should not rush. So C would be again a good option. But I'm saying what scenario C would be a bad option despite we are in the middle of the word round. Why? Why? I'm in the middle of the word round and I need to act now. The answer is if the harm is being going on. Please be very mindful of that. If someone is doing the harm now, like he is saying now, because the effect has already happened and he left the room from the stem. So the damage has happened. So no point from stopping him now. But if he's been insulting the patient currently, you should stop him, because they might play with the words. They are telling you, you are hearing or overhearing your colleague is abusing the patient. Now this is being going on now at the moment. You should stop him now, no matter whatsoever, even if it was a word round. Why? What's the philosophy behind that? Because if you are stopping him now, you are preventing a damage from happening. So there is a point from delaying the care, and you are delaying the care for just maybe less than 5 minutes. So if someone is committing something bad now at the moment, you have to stop him now. That includes insulting comments, derogatory comments, racism, even being rude. You have to stop him, because that's being going on now. But if they mention it in a way that has happened already, no point from stopping it now. It's already passed. So that's the trick. So C is the best option here, because the harm has already happened and I'm in the middle of the word round. I have to prioritize the word round, but I should not dismiss this issue. So C is better than B, is better than A, and definitely A is better than B, because A, I'm doing no favor to my colleague, but B, I'm doing no favor to my patient. So in Delta, D, overtly disagree with Dr. Lee to show the patient you are on her side. So this is pretty much similar to A. I'm standing with the patient against my colleague. So C would be the best option, Charlie, and B, Bravo, would be the worst one, because I'm telling her, expect us to mistreat you every time we have stressful day. That's not acceptable. So Charlie is number 1 and Bravo is number 4. Which is better, Alpha or Delta, A or D? Who would like to tell me? To report him prematurely, or to overtly disagree with him to show the patient that you're on her side? Any thoughts?
Delta before A,
Why?
because A you may cause too much harm to your colleague, but Delta you are causing some harm to him by like having disagreement to him, but at least you address your concern with him directly.
Very good. And this is our way of thinking as a clinician, which is not correct here. I'm sorry to say that. Why? In SKT, you are being judged against your judgment professionally. So which is more professional? More professional to report your colleague when he's doing something bad to the patient, or to overtly disagree just to show the patient you are on her side? Which is more professional?
I think A is more professional.
Reporting, definitely. So in A, this is an official channel. This could be potentially the best option, but not now, at some point. So it is something professional, but the problem is it's coming prematurely, but it is professional. However, D is never acceptable. What I'm trying to say, in SJT, you can never solve a problem by causing another problem. You cannot act unprofessionally yourself. You are not justified. No one would excuse you to be unprofessional because your colleague has been unprofessional. No, he has been rude. You cannot overtly disagree. Look at this. Look at the actual phrasing. It's really tricky. Just to show that in your hasad. Is that your aim, your goal? No. I'm doing this to support my colleague in the first place because he did less. I want him to be a better doctor, and to save the dignity of the patient. I'm not here to take sides. It's not like a debate or something like that. So the action is very unprofessional, and the goal is very unprofessional as well. An SJT is professional exam, professional dilemma. You have to be professional. A is very premature, I agree, but professional. D, you are doing nothing. You are not supporting the patient. Now you overtly disagree. Okay, that's fine. How would you calm this patient? How would you save her dignity? Nothing. You are just standing with her. So what? But by reporting, someone will investigate this. Someone will offer an apology to the patient. But in D, you are just being very unprofessional and very slang and just trying to, okay, I'm taking side. This is not your job. Your job is to correct things, to support people, support your colleague, and support the patient as well. So this is the way you should work the SJT out. After you do a question, you have to analyze. Look at this now. From my analysis in that question, I have concepts and skills. I've learned concepts and I've acquired skills. They are different. What concepts are we talking about? Patient dignity. I can never accept someone is mistreating the patient. Despite they're having stressful day or whatever, that's not acceptable at all. So patient dignity must be preserved, no compromise for the patient dignity at all. You cannot do that. This is the first concept. The other concept is inter-colleague relationship. I should support him. If he is not listening, I should escalate, and the escalation should be discuss with your colleague, then discuss with the senior, then complain to senior, then to report. Report is the last resort. I agree with you. So I've learned no unprofessional treatment at all. You cannot treat a problem by being unprofessional. That's not acceptable. So what skills I have learned, acquired? Okay, that's very good. Someone mentioned that if he was racist or he giving insulting comments. So there is a difference between being rude and being racist. If you are being rude, I need to support you. I need to tell you that was not the best and you need to apologize to the patient. But if you are racist, I'm not supporting you. Being racist, that will justify me taking very extreme action. Let's go back. So D here in this option would be justified if he was racist, telling, oh, you are very obese, you are very short, you are very, If he is racist, now this is beyond the correction, beyond the support. Being racist to steal something, things that very, very extreme that the NHS and the GMC, they are not supporting. There are quite a few, to be honest. So one of them being racist. If you are being racist, again, I should not stop the care now. I will go with C because patient care is more important. But D will come up, will be maybe number 2 or number 3. Because if you are being a racist, I'm justified to challenge you whatever I do. Why? Because you are beyond that level. You are now, you don't need support. Because when someone is rude, I should presume they lack experience, they lack understanding. Someone should explain to them. But when you are racist, you don't need explanation. You are racist, you are a bad person. This is nothing to be explained to. So, this is the skill I've learned here. If you are rude, I need to be soft. If you are racist, I can go for extreme actions. Again, but you should not be unprofessional, like to be racist yourself. No, but you should challenge that. It's better to challenge him professionally, but if you challenge him a little bit unprofessional, let's say, that's somehow acceptable because he has been racist. It's not the best, but it's not the worst. Okay, now I acquired the skill when to report. The action should be repeated and the effect should be explained to my colleague. After fulfilling these 2 steps, I can report immediately. So I've learned something very, very important. Is it concern or a fact? So we are talking about this in the next example. So who should take this example, please? Who's taking this question? Someone should volunteer, please. Come on.
Sorry, I have a question about the last question.
Okay, so you are doing this question after we answer your question.
That's okay. So you said that if the F2 left, so that's why you could do nothing and come back to it. So
Exactly.
let's say both of you are conducting the ward round and he is already talking to this patient. Maybe you are just, walking onto the ward and then you actually hear this going on, this rudeness going on. So, or
The best
yeah, you
course
hear
of
it going
action
on,
would be-
or maybe you've split the ward round such that the curtains are drawn. You're examining patient A, he's the one responding to patient B. And then behind the curtain on your side, you and your own patient are hearing this rudeness going on the other side of the curtain. Do you then leave your own patient to go and, correct your colleague?
Definitely.
Okay.
Why? Because you have to understand the theory behind that. Now, if I'm leaving my patient and stopping that, I'm stopping actual harm. This is my goal in the NHS. I'm leaving my home every day, 9 a.m. to attend the hospital to stop the harm. So I'm stopping the harm now. I'm achieving something. So I'm justified to leave my patient for a few minutes, then come back because the harm is being going on now. But if something happened, just treat that later and prioritize the care. Why?
Okay.
Because if the insult is being going on now and no one stopped that patient will automatically disengage and he will never accept the treatment. And we know in the UK, in NHS and GMC, you cannot force patient to take treatment. He should accept that. If he's been insulted, she will never accept. So indirectly, I'm saving this patient. I'm leaving that patient to be engaged with the care. So that's why I should stop it now. It's patient care as well.
Okay, thanks.
No,
what's the next question?
Thank you so much for doing that.
You're F2 on a ward round on a busy ward. The SPR is presenting bed 4. While discussing the patient's social history, SPR says, well, it's from that southeastern part of the town. You know how these people are with compliance. The remark is clearly heard by the patient, who looks upset, but the bedside nurse, who is from the same ethnic background, looks shocked and uncomfortable. The ward round continues to the next bed.
Pretty much similar thing. Now this is racist. It's not even being rude, but you have to be careful. Now the question is 3 best of 8. It's not a ranking. It's different.
Okay.
You need to pick 3 answers. They are solving the problem, and the methodology and the mentality should really be different. And we are discussing the anime, so they are pretty much similar. Someone is giving comments, and you are in the word round, and you are like third party here. You are not doing the comments. Okay, so how would you take this?
Do you want me to read the options?
If you don't mind. Yeah.
Okay, so A, stop the round, pull the SPR aside and say, that comment was racist and unacceptable.
What do you think about this? Is it good or bad?
So the round has moved, but yeah, that's this racism is completely unacceptable. So yeah,
Unacceptable, but we have learned something. Is the racism being going on, or something happened already?
It's already happened because we're now on the next patient, but still.
Okay, so would you go for A or would you drop A?
I want to go through the options first to see if there are better ones.
No problem. Yeah. Okay, fair enough.
B is to apologize to the patient and the nurse for the experience. That's not bad. Apology does not necessarily mean saying sorry for myself, but just for the experience. So that's empathy.
You're not accepting liability or anything. Okay.
Yeah. C is to say nothing during the round. Privately tell the SPR that the comment was inappropriate. No, not for now. D is to reflect on the whole experience. Let's keep that to later. E is during the round, subtly redirect. Actually, the patient's non-compliance is due to language barriers. That may not be entirely true. We're not told that the patient does not understand English, even though they're from a different part of the town. After the word round, email the SPR supervisor about the comment. So this is like reporting, but is this your first time? Even though racism is unacceptable, I'm not sure an email is the next step. Then report the SPR to your consultant in your break. Document the incident in patient notes under social history. Okay, so I think I would go for A, B, and I'm just looking for a third one. After the word round, email the SPR supervisor. A, B, and maybe G.
Okay. First of all, thank you so much for taking the question.
Yeah.
Maybe 50 doctors are keeping silent, so you've been brave enough. So again, you need to analyze the STEM. And I told you in one of the modules, they kept lengthy options. So it's pretty much similar to one of the questions in the exam. So now let's pick the hints one by one. You are F2, that's very good. Word round, okay. This is the first hint. Now I'm in the word round. So anything that is non-clinical and happened already, I should not stop the word round for. This is the rule. Unless something is being going on now, I'm justified. Otherwise, I should not stop the word round. That's the whole idea why they are keeping so much details. So word round, this is one. And busy word, not just busy word. It's not just word round, it's busy word. So you need to be careful about that. And the registrar is presenting one patient, and he's being racist by talking about part of the town, they are not compliant, and that's very inappropriate. So he did that remark already, and this has been heard by the patient and by the nurse. And the word round continues to the next bit. So That happened already. That's why A makes no sense. A is a good option if he is doing that now, or that was the last patient. We have no clinical care to continue. Now I should address it immediately, but it is not the case. You should not stop the word down. So A made no sense. B, apologize. Again, that's very good. You've mentioned something nice. Even offering an apology does not mean I'm accepting liability. So is B a good option here? The answer is no. Whom would tell me why B is not a good option here? It's very tricky, but B is not a good option here. Any thoughts? Why B is not a good option? Because basically, you cannot apologize on behalf of someone. You are representing the organization, the trust, the NHS, the GMC. You can apologize for the experience. You can apologize for the encounter. You can apologize for the feeling, not on behalf of someone. So you are saying that B is not apologizing on behalf of someone. No, I'm apologizing on behalf of someone. How come? Because I cannot apologize on behalf of someone. I cannot apologize when my colleague who did the mistake is still present. I cannot apologize. That means I'm practically apologizing on his behalf because he is there. If he is not there and he left, I can apologize because I'm the only one left and I'm representing the organization and I'm taking lead. But if he's still there, I should support him to offer an apology. So I can never apologize when the sinner, the one who did the mistake, is still there, because I'm practically apologizing on his behalf, which is not acceptable. I'm not his lawyer or solicitor. That's why B is not a good option here. That's very subtle. C, say nothing now, which makes sense because we are continuing the word round. Then privately tell him the comment was inappropriate. That's good. I'm challenging him, but privately. Can I challenge him openly? Yes, if he's doing that now. But since the harm has happened, I should not expose him in front of everyone. That's not professional. So privately, that's professional. But is it appropriate to say inappropriate? Because we have learned in SJT, you should always give a justification. You should say that was blah blah blah. I felt this. You should not give a blunt comment, something inappropriate. However, because you are challenging racism, you are justified to say so. If he was rude or he did another mistake, it is not nice to say inappropriate because you are not explaining anything. He is not getting any benefit. But because he was racist, you don't need to explain because racism is universally unacceptable. So privately, that's good because the harm has happened. Inappropriate is here, appropriately inappropriate here because we're talking about racism. If he was rude, I cannot use the word inappropriate because that's not explaining the issue. I need to support him. So C is perfectly appropriate here. D, reflect. That's good, but maybe later on we have to pick 3 answers. So it might not be the best at the moment. So I'll keep it aside, but it is good. You have to reflect. You have to show as a junior doctor reflective behavior, but maybe not the top 3 options. So C is a good one. D is potentially good. E, during the word round, subtly redirect. Actually, patient's non-compliance is due to language barrier. This might be fact, might not be the fact. So I'll keep it. I'm not sure. F, after the word round, email my registrar supervisor. This is not the best. If you are escalating, you have to escalate to your supervisor, to your boss. So his own supervisor might not know you, so it's not the best step. But it is form of escalation, that's fine. And after the word round, that's even safe. Report him to your consultant. Okay, this is a new skill here. When you have 2 options, they are exactly doing the same job, which is escalation. You cannot choose both. You cannot ignore both. Believe me, take this from me. One of them would be correct most of the time. So you cannot take both. You cannot ignore both. You need to choose one of them. So F or G, one of them is correct. H, document the incident in the social history. That's very inappropriate because social history is a social history. The patient note is a legal document. You cannot document whatever. The encounter and this rudeness, you can document that in DATEX, clinical incident form, I agree, but it's not social history. So H is totally inappropriate. So now I have C, D, maybe E, and one of G and F. So I need to make up my mind. Is it D or F? It's definitely G. Why? Because I'm reporting in my break, which is after the word round, F after the word round as well. So they are equal here. However, I'm emailing and the email is carrying some delay. Okay, that's acceptable. And to his supervisor. Now I'm reporting him to my consultant, which is my consultant and his consultant. How come I say that? Because we are on the same team. He's my registrar. So the consultant will be for both of us. So he is mutual senior for both of us. I have a good rapport with him and he is having good rapport with the registrar. So that makes more sense. So G will automatically be cancelling F. So the answer is C, Charlie, and G. So why D is not a good option here? Because during the word round, I can never ever during the word round make a reflection. That's not safe. I'm taking care of the patient, taking history, and doing a reflection at the same time. You might say, oh, they didn't mention reflect during the word round. No, they mentioned indirectly. By telling you in the stem, you are in the word round. And they didn't specify any time during the option. That means immediately, now. If they want to make a time specific, they will go like E and F during the word round, after the word round, report in your break. They didn't mention anything. That means it's immediate action. You have to understand that. So in this question, the answer will be Charlie. Echo is not an ideal, but it's the least harmful, the least incorrect. It's an assumption, but it's not, even if the assumption was not correct, it's not going to harm anyone. But D is definitely unsafe. And F and G, they are duplication. You cannot go for the same action twice. So the analysis for this question, again, I made up this question. So the analysis, concepts versus skills. The concept here, the apology. No apology on behalf of someone, and no apology in presence of the sinner. If he did the mistake and he's still there, I can never ever apologize. That's number one. I should learn this way. Racism, you have to apply zero tolerance and you have to challenge. And you have to immediately escalate. Why? Because it's racism. You are okay to approach him privately or to challenge him directly according to the situation. And you, on the same time, you can escalate. You can communicate with him and escalate in the same time because it's racism. So word round represents patient safety. I cannot stop that. So these are the concepts that I have learned. Every single question should be worked out this way. So what skills I have acquired? Okay, there is ongoing and there is already committed mistake or sin. So if it is ongoing, that means I need to stop that because this is like a patient care, patient dignity. Okay. But if something already committed, I cannot stop that because I should prioritize the patient care. This is the subtle skill I need to learn. So patient care is stopping racism, which is more important. If it is ongoing, it's not like when it's already committed. That's a big difference. So again, when they are giving me an option without specifying the time, that means it is now. Best course of action now. I cannot now do a reflection. That makes no sense. I'm in the middle of the word round. And I cannot duplicate myself. I cannot do the same action twice, the same outcome twice by F and G. That's why the answer here is C, E, and G. So what techniques and resources you should utilize in SJT? You have to follow this way. Analytical study. SJT is not like clinical. Clinical is evidence-based medicine practice. It's universal wherever. So SLE is SLE everywhere, and Mailer Raj, whatever. So something that you know. But SJT is different. It's judgmental, and it's not unethical. It is situational. The same question will be answered differently if they change one word. The situation has been changed. So it's a situational. So you have to analyze every single question to make up points, to understand the concepts, and to acquire skills all the time. You could start by doing the foundation paper. They are 4 papers. They are the main resource of the SJT because they have been written and answered by the exam writer. So you need to start with them. You can expand your study by doing Oxford book, 250 book, and some online books. You have to read the GMC called Medical Practice at least once. It's a vague general statement, but after doing question banks and foundation paper, that might make some sense. So read it afterwards. That's why they are in order: analysis, resources, then GMC multiple practice. Please, please, please avoid the online question bank because they are written according to the methodology of the author, and he is not the writer of the exam. You will hardly, after a long time and spending time and money, will understand his methodology and his technique, but he is not the one who is writing the exam, and you have just understood this exam is not evidence-based, it's just judgmental situational. So his judgment is different from the examiner judgment. So don't waste your time and money. So I'm leaving this for you to read. This is one of your colleague experience. She sat for the exam for the first time in September, and she scored in the SAT 275, which is very high score. So I thought that might be useful. While you are reading this experience, I would be happy to take questions if you want to ask anything. In the meantime.
Thank you so much, Dr. Kosai, for this insightful session. We would love to hear feedback about the session as well. So I just typed the link for the feedback in the chat box, and we are now happy to take any questions. So the first question was about the second question about the answer, why E is a better option. If you are happy to answer that.
Oh, yeah.
Thank you.
That's a good question. Again, I've missed something very important. Now, you have to understand that in such a question like 3 best of 8, the only way to score 12 out of 12 is to know why every single answer is incorrect. This is the only concrete way. So we have learned A is unsafe. I cannot stop the word round. This is a patient care. B is very, very unprofessional and illegal. I cannot apologize on behalf of someone. I'm not his personal solicitor or personal lawyer. I cannot do that. So A is definitely not going to be one of my options. B is definitely incorrect. D is definitely unsafe. I cannot, during the word round, open my laptop and do reflection. That makes no sense. It's unsafe, unprofessional. So that's why A, B, and D are excluded. F and G, they are pretty much similar. I need to pick one of them. I cannot exclude both. I cannot take both. And H is very illegal. I cannot write rubbish in the patient records. This is a legal document. What I'm trying, as I told you, the stem and the options, they are made up. I made them up. So I tried to keep E. It's not an ideal answer, I agree, but it is the least harmful, because when you are showing the examiner, I understand why A, B, D, F, and H, they can never be an option. That's why I'm going for it. It will give you a full mark. So E is not an ideal answer, it's an assumption, but it's harmless assumption. It's not going to harm anyone. Not going for any of the other incorrect options that are showing you are missing something. You are missing one hint, you are missing one concept. That's why. So E is not an ideal. If I got better option, I will keep it. But this is the exam works, the way the exam works. You have to exclude the other options.
Thank you so much, Dr. Kosai, for this really interactive session. Any more questions? I would also kindly ask if you can fill the feedback form. That would be great and help us to improve. So Dr. Ellen is now saying that I feel like A is a good response.
Which question one or two? Which one of them?
I think it's the same, the second question.
Yes. No, you cannot stop the word round. That's definitely unsafe. You can never ever stop the word round, ever, because you are prioritizing dealing with non-clinical matter or task over clinical. That's definitely against SJT. You cannot stop the word round at all. Unless you are preventing harm from happening. Someone is being racist now. That makes sense. Otherwise, you cannot stop the word round at all.
It's quite a common question that commonly asking about that there is ongoing like word round or grand word round or busy word. So it's quite common.
Yeah.
Thank you so much, Dr.
No.
Do we have any question? I think Dr. Jose will be happy to share the slides afterward.
Yes, yeah.
Thank you. Any more questions? I think there is no more questions. So thank you again, Dr. Qusay, for
No
this, for your important time to explain the SJT and your tips and advice. Thank you so much.
No
And
worries.
good
Thanks
luck.
for having me. Good luck for everyone.
Thank you. Good luck, everyone. Thank you so much for your time. Take care.